This is Teresa Mclean, and today we're going to talk about nursing care of patients with neurologic problems. The first part of this discussion will be about general points that you already have heard before, but hopefully we'll just retweak your memory so we can gently glide along as we talk about other problems that you haven't discussed before. So let's get started. As a review, we know that the neuro system controls bodily functions and is related to every other body system. We know that patients who suffer from diseases of other body systems can develop neurologic impairments related to that disease. So if you think about your diabetic patients who develop neuropathies, then you can see how some other diseases all impact the neurologic system. I want to go back and remember that the neurologic system is divided into three parts: the central nervous system, CNS, the peripheral nervous system, the PNS, and the autonomic nervous system, the ANS. The CNS, remember, includes the brain and the spinal cord. The peripheral nervous system includes the peripheral nerves and all 12 cranial nerves. The autonomic nervous system is a division of the PNS and contains the motor neurons that regulate the activities of visceral organs and affect smooth and cardiac muscles and glands. And if you remember the two parts of the autonomic nervous system being the sympathetic division, fight or flight, and the parasympathetic division, rest and digest reactions. So remember, parasympathetic is your baseline body functions. Now let's go over some other important points to remember for the neuro system. Remember, these are things you've already heard, but bear with me. The respiratory system is located, or the respiratory center, is located in the lower brainstem. We know that lesions in this area may result in abnormal respiratory patterns. It is more important that you recognize abnormal breathing patterns than to be able to name the abnormal breathing pattern. So, in the gist of you trying to recognize or trying to go in and assess a patient and seeing that their breathing is not unlabored and regular, people sometimes are like, they play a guessing game and go, oh, is this Cheyne-Stokes? What is it? What am I going to tell people? Well, what you're going to tell them is what you see, what the respiratory rate is, unlabored, are they taking small breaths, deep breaths? So you're going to be very descriptive. So don't worry about the name of the breathing pattern, worry about how they're breathing. The second point is that the brain needs two major nutrients to remain viable. Those are glucose and oxygen. We know that the brain uses 20% of the body's total oxygen consumption, and this is necessary for the metabolism of glucose. We also know that glucose is utilized by the brain at a rate of 60 milligrams per minute, which is about 25% of the body's total glucose consumption. The third point is the Monro-Kelly hypothesis. And if you remember back, you remember that with this, we have to think of our skull as this big vault, and I like to call it the cranial vault. So if you think or can liken it to being in a bank vault, you have a very rigid container with multiple linings. But inside that, you have all kinds of soft things. So the soft things inside the skull would be the brain, the cerebral blood volume, and the cerebral spinal fluid. The brain accounts for 80%. The cerebral blood volume, CBV, is 10%. And the cerebrospinal fluid is the other 10%. We know that each of these volumes in normal states will remain relatively stable. The Monro-Kelly hypothesis states that a change in volume of any one of the components, be it the brain, the cerebral blood volume, or the cerebrospinal fluid, must be accompanied by a reciprocal change in one or both of the other components. If this reciprocal change is not accomplished, the result is an increase in intracranial pressure. Well, if you think about it, the brain really can't do much to help with the Monroe-Kelly hypothesis. There's nothing much it can change. Generally, it's the culprit of change, meaning that when you have an injury, the brain swells. So the two other components that need to come up with the reciprocal change are the cerebral spinal fluid or the cerebral blood volume. So one or both of these must change in order to accommodate the brain in this rigid vault. Brain volume is about 80% water, with the majority being intracellular. The cerebrospinal fluid consists of 99% water, which contains proteins, sodium, chloride, potassium, bicarb, and glucose. Another point to remember or to think about is the blood-brain barrier. If you'll remember that the blood-brain barrier is a network of cells and membranes in the brain capillaries. It's very selective in terms of membrane permeability and molecular size of the substance attempting to enter the cerebral circulation. It is permeable to water, oxygen, lipid-soluble compounds, glucose, some amino acids, and carbon dioxide. It is slightly permeable to electrolytes. We do know that infection and trauma can alter the blood-brain barrier and alter the balance of some proteins, water, and electrolytes. We do know that the brain volume is controlled by this blood-brain barrier, whereas the cerebral blood volume is controlled by cerebral blood flow. And you can go back and review or remember what you were taught in pharm about the blood-brain barrier and the different medications that pass and don't pass. Autoregulation is the last big point I want you to remember for the neurosystems. Autoregulation allows the brain to maintain a constant blood flow despite changes in systemic blood pressure. It is a compensatory mechanism of automatic constriction or dilatation of cerebral blood vessels to either changes in systemic arterial pressure or blood levels of carbon dioxide and oxygen. So this autoregulation actually makes it able to change the diameter of blood vessels to maintain constant cerebral blood flow. So when systemic pressure rises, the vessels constrict to protect the brain from blood engorgement and to protect cerebral tissues from the full impact of the systemic pressure. When systemic pressure falls, the reverse occurs. Cerebral vessels dilate in an attempt to increase cerebral blood flow. We also know that the brain is very sensitive to levels of carbon dioxide. We know that the cerebral blood vessels will dilate in response to hypercapnia, a PCO2 greater than or equal to 45, and that vessels will constrict in a response to lowered levels of PCO2, less than 35. So our goal is to keep the PCO2 within normal limits to maximize blood flow and oxygen, thus giving no increases in intracranial pressure. As far as oxygen goes, vessels usually dilate in response to low levels of oxygen. We do know, however, that there is problems with autoregulation when the systemic blood pressure drops to less than 50 or greater than 160. Let's talk about age-related changes in the neurologic system. We know as we age there is a delayed response to stimuli. We know that we have slower reflexes, and we need additional time to respond and process verbal stimuli. We know that as we age, we're a little more forgetful. We can improve this by using brain games or memory aids, such as lists, crossword puzzles, or some fun computer programs, which ask our brain to put things in sequence or in order. We also know we have a slower response to changes in balance, so we have an increased risk for falls. It is said that there is less readiness to learn, that we can learn new skills when it is related to a previous one. And that's very important when we're teaching elderly patients something that relates to their care. How do we want them to remember it? Well, one easy way is to relate it to something that they already know. Finally, we know that as we age, we get more easily distracted. So when you're doing teaching to your patients, no more than 30 minutes of teaching at a time. I love this cartoon. It says, "Good morning, Mr. Smith. Can you squeeze my fingers?" "No way," says the patient. The nurse says, "I just need to check your strength." "Yeah, right. My grandpappy used to pull that gag on me all the time." The nurse says, "Come on, just squeeze my fingers." "Nope, I'm not falling for that," the patient says. "Okay, how about you raise your arms over your head," the nurse says. And the patient says, "Why? So you can tickle my armpits?" So how many of us have gone into patients' rooms trying to do neuro checks and there's a lot of monkeying around? That's the fun part. The not so fun part is when patients really do it. So what are some common neuro assessment findings? First of all, pain. In neuro patients, pain can be a headache, back pain, or pain in the extremities. Patients with neuro problems will complain of dizziness. So what you have to decide, is it lightheadedness versus the room spinning? So we have to look at causes. Were there sudden changes in movement? Is this as a result of diabetes, changes in glucose levels, dysrhythmias, anxiety, or possibly ear problems? Are there sensory problems? Alterations in sight, taste, smell, and feeling. And when I'm talking about feeling, I'm also talking about numbness, tingling, paresthesias, and the pain that is associated with that. And besides that, they have motor problems, weakness, problems with coordination, meaning balance, gait, clumsiness. A lot of times we'll see involuntary movements, tremors, or tics, you might say. And finally, another common neuroassessment finding is alterations in mental status or loss of consciousness. So let's go back and review what is a neuro check. It has several components, and I like to say there's about 5 components. The first being an assessment of the level of consciousness. This is the most sensitive indicator of changes in the neurostatus. It takes into determination the level of arousal and wakefulness and the ability to respond to stimuli. It also takes into account orientation. So we have to determine, determine the orientation to time, place, person, and event or situation. What we do know with orientation is that orientation to self is usually maintained except in advanced dementia. We also know that orientation to time is usually the first lost. In many patients, we'll use the Glasgow Coma Scale in critically ill patients to assess their level of consciousness. Vital signs is another part of the neuro check. When you look at each vital sign, in neuro patients, we look at the blood pressure. It's very labile in neurological events. Generally, we see a widening of the pulse pressure, evident with increasing intracranial pressure. Pulse usually will show bradycardia with increasing intracranial pressure. So as pressure builds up, generally the pulse gets slower and slower. The respirations or respiratory pattern is dependent on the pressure being placed on the brainstem, so you may see varying respiratory patterns with neuro patients. One thing we keep in mind when we're looking at vital signs is Cushing's triad or response, meaning a wide pulse pressure, usually an increase in the systolic blood pressure is noted, bradycardia, and uneven respiratory pattern. So those are your three things that go in the Cushing's triad or response: wide pulse pressure, bradycardia, and uneven respiratory pattern. The third part of the neuro check is the pupillary response to light. We often look at pupils to see if they're equal, round, reactive to light, and accommodation. P-E-R-R-L-A. Pupils can be pinpoint to fully dilated. Some are due to narcotic administration, others are due to decreasing level of consciousness. And we know as patients' level of consciousness decreases, oxygenation to the brain is usually one sign, and pupils become fixed and non-reactive. Generally, when we're looking at pupillary response to light, we like to measure pupils in millimeters, anywhere from pinpoint or going up to 1 millimeter all the way up to fully dilated, which can be 10, the whole aspect of the iris. The fourth point in a neuro check is to assess the strength of hand grips and movement of extremities bilaterally. You always want them to squeeze your hands at the same time. Never give patients your full hand to squeeze. Take your pointer finger and your middle finger and wrap them around each other, and then give the patients those two fingers and have them squeeze. This way you won't have that chance of having your hand squeezed too hard and suffering damage. And it's always good for most of us when we have people, grasp our hands or squeeze our fingers. If they're really listening, the appropriateness to a neuro check is to say, let go. So for most of us, it's very reflexive to wrap our hands around something. But if they're really cognizant and following commands, then when you ask them to let go, they will. So when we assess strength of hand grips and movement of extremities, we want to make sure we do them bilaterally at the same time, not do one hand and then the other. Have them do both at the same time. The last part of the neuro check is sensation of touch or pain in the extremities. And this is usually done by using something like a Q-tip and breaking it and showing people that, letting people feel what it's like for a soft touch, or the other end, the broken part, just barely touching and say, okay, this is a painful touch. And then have them close their eyes and you touch soft and the painful side to see if they can differentiate. All right, let me just go over. This is the Glasgow Coma Scale. I just wanted to bring it up again. What we do know is that it consists of 3 areas: eye-opening, best motor response, and best verbal response. The best score that you can get is 15. Anything of a score of 8 or below is considered comatose. So the best score, 15, means that they open their eyes when you call spontaneously. They can obey commands, and patients are oriented. All the rest come underneath. The worst response is no response for any, and we definitely know these patients are usually not going to survive. So please review the Glasgow Coma Scale. We are not going to talk about the nursing care of patients with neurologic infection and autoimmune disorders because you all already have that. But I love the picture here that goes over the different lobes of the brain and what it controls. So you can take a look at that and just do a little review. What we are going to talk about is nursing care of patients with back problems or injuries. One thing that you're going to see a lot is the term degenerative disc disease. We know that as we age, the bones in general get a little bit weaker. And for some patients, they have this ability for this degeneration of bones in their back, or the vertebrae in their back, to degenerate. So with degenerative disc disease, we know it leads to herniations of intervertebral discs, and with that we see compression of small nerves with pain. So with continuous pressure on the nerves, it will result in changes in sensation and deep tendon reflexes. So let's talk about herniated intervertebral discs. We also know this as a ruptured disc. So as a way of review, let's say that the discs are located between the vertebrae, and they're made of an inner portion called the nucleus pulposus and an outer portion called the annulus fibrosus. A rupture occurs when there is weakening or trauma that allows the nucleus pulposus to protrude, thus causing pressure on the nerve roots surrounding it. So there is your little patho for the day. The incidence, it can happen at any age, but generally we see it increase with age, and it's most commonly seen between the ages of 30 to 50, more so in men than women. Occurrence is generally around the cervical areas from C5 to C6, C6 to C7, and the lumbar areas L4 to S1. Causes can either be spontaneous, meaning there's a weakening in the disc space, or by trauma, meaning you lifting something too heavy, or a fall, or turning a patient in bed. We see herniated intervertebral disc as well with patients. I mean, if you're thinking about the cervical discs in your neck, my big pet peeve is always to be wearing your stethoscope around your neck. We know that your neck is not a hanger, but over periods of time, if you're wearing a very heavy stethoscope around it, you are putting pressure on those discs. And over a period of time, you can cause these herniations to occur. So there's my soapbox. So, assessment-wise, what do we see? Pain being the biggest one. So with the C5 to C6, we'll see pain in the neck, the shoulder, anterior upper arm, the radial area of the forearm and thumb, paresthesias in the arm and along the thumb and forefinger, and generally a stiff neck. So range of motion is lost. In the L4 to L5 area, We may see pain in the lower back that radiates down to the hip, as well as the posterior lateral thigh, the anterior leg, down the dorsal aspect of the foot and great toe. You can also have muscle spasms and paresthesias. If you have a rupture from L5 to S1, the pain will be mid-gluteal. It'll be posterior thigh, calf to heel, and plantar section of the foot to the 4th and 5th toes. You'll also see paresthesias along the back side of the leg and impairment in walking on your toes, as well as muscle spasms. Anytime you have anything happen from L4 to S1, we always know that there's going to be a decrease in movement or range of motion. So generally people have pain aggravated by sitting, straining, sneezing, coughing, climbing stairs, riding in a car, or even walking. Some of the nursing diagnoses for herniated intervertebral discs include, number 1, acute or chronic pain, 2, impaired physical mobility, and 3, a risk for injury. With these anterior cervical discectomies, we usually post-operatively, what we're looking for is to check for voice quality because they do have a small incision at the front of the neck. So we want to make sure that the vocal cords didn't get affected. So check for voice quality. We want to make sure that patients can swallow, that they can lift their arms above their head, that they can make a muscle, that they can squeeze hands, and that they can stand, breathe, and there's not much neck swelling. Complications from this type of surgery can be carotid or vertebral artery injury. They can have laryngeal nerve damage. They can have esophageal perforation or airway obstructions due to swelling. Or they can have weakness of muscles supplied by the nerve root, which is more common in the posterior cervical discectomy. Okay, so for interventions with the anterior cervical discectomy, we want to make sure that patients have good shoes or slipper tread socks. Most will usually have a JP or a TLS drain, very small little drain, which are generally discontinued on post-op day 1. Physicians may order a cervical collar, usually soft collar for comfort unless they've had an extensive anterior cervical discectomy or posterior cervical discectomy. Movement, we want to make sure that they turn their upper body, not their neck. We want to make sure that they get up out of bed and ambulate within 4 hours of surgery. And we want to assess for bleeding and hematoma formation to see if there's any excess neck pressure or pain at the incision. We also want to watch for serosanguinous drainage, which is usually indicative of a dural leak. The other surgery that may occur is an anterior lumbar interbody fusion or a posterior lumbar interbody fusion, going by the acronyms of ALIF or PLIF. Or some patients will have a lumbar laminectomy, which is removal of all or part of the vertebral lamina for exposure of the spinal cord and nerve roots. They can also have what they call a micro lumbar laminectomy, with or without fusion, pinpointing just a very small area. Post-op assessment with these patients are wound integrity, bowel sounds, nausea or vomiting, back pain, bowel movements, abdominal distension. We need to make sure that they're able to move their legs, that they can lift their legs off the bed, and they have good dorsi and plantar flexion at the ankles and can bend their knees. Complications related to this type of surgery are usually abdominal related, so bowel or colon issues. They can also have urinary retention issues, nicking of the dura, hemorrhage, or infection. Interventions include log rolling if they have had a laminectomy. If they've had a micro procedure done, then there's little or no limitations on movement. Generally, for all back patients post-op, no sitting for longer than 20-minute intervals, and definitely no sitting at 90-degree angles. Some may have back braces, which are custom molded, or abdominal binders. They may or may not have a drain, and that would either be a hemovac or a JP drain. We'd get physical therapy for gait assessment and exercises. And we also want to encourage people and tell them to get up and move, but it may take 6 weeks to heal. Now, some patients will come in and have an ALIF procedure done, the anterior lumbar interbody fusion, where the surgeon will go in through the anterior aspect of the abdomen, and that way they can visualize that anterior part of the vertebrae. And then 2 weeks later, they'll come back and have a posterior lumbar fusion done. So they'll come in and they can see the actual posterior part. So you're looking at 2 different recoveries, and a very painful recovery at that. But the biggest thing patients can do is to move. And let's not forget that anytime you have surgery involving the abdomen or the back area, or just surgery in general, that propensity to get pneumonia is still there. So IS is very important. Okay, let's take a break for a minute. Now I want to talk about spinal cord injuries. Spinal cord injuries are one of the biggest major health problems in the U.S. Presents patients and families with the task of dealing with lifelong problems, both emotionally and functionally devastating problems. About 12,000 new cases per year occur, and that doesn't account for those that die before reaching the hospital. We know about 259,000 people live with a spinal cord injury or an SCI. The average age is usually 40.2 years, and about 81% of spinal cord injuries are male. 66% occur in Caucasian population, 27% in the African American population, 8% Hispanic, and 2% Asian population. The average hospital stay is about 12 days in acute care, followed by 37 days in rehab, with about 5% of those patients ending up in nursing homes or extended care facilities. The leading cause of death in spinal cord injury patients is pneumonia, generally followed with pulmonary emboli and sepsis. A long time ago, it used to be renal failure, but we've gotten a lot better about that, taking care of that situation. We know that this is a long series of nerve cells and fibers that go from the base of the brain to right above the tailbone, and it ends about at L1 to L2 level. The spine is the vertebrae that encases the cord. So let's make sure we know what the spinal cord is and what the spine is. Spinal cord injuries are usually in two different categories. One traumatic and the other one being non-traumatic. Of the traumatic injuries, we know that 42% are usually due to motor vehicle accidents, 26% due to falls, 15% due to violence such as gunshot wounds, and 7% sports. The good thing is that violence and sports categories have decreased, but the falls category has increased over the years. We don't know really, we're not really sure, or haven't pinpointed exactly the reasoning out why these non-traumatic injuries occur, but we do know they occur over time. So arthritis can cause problems with the spinal cord. We know that cancers can invade the spinal cord, sepsis or infection such as meningitis. Blood vessel problems are another reason, and bleeding or inflammation can put pressure on the spinal cord, and so those are your non-traumatic reasons. And generally we just have to make sure that we know that non-traumatic reasons occur over time, whereas traumatic are. We know that the spinal cord does not tolerate injury well, and that there is usually no functional regeneration of neurons. With severe spinal cord injuries, they can cause death. We know most spinal cord injuries involve C5 through C6 and T12 through L1, with the most common injury occurring right at C5 to C6. And then number 2 would be T12 to L1. Keep in mind that any problems above C4 can result in respiratory arrest. When spinal cord injuries occur, blood pressure and blood flow drop dramatically. As the blood pressure and blood flow decreases, inflammation sets in, and nerve cells at a distance from the injury begin to die. The association of immediate loss of all sensation and complete loss of all movement below the spinal cord injury, lasting more than 24 hours, carries a grave prognosis of recovery. There are a couple or several types of spinal cord injuries. The two major types are complete and incomplete. And let's talk about complete first. Complete can be either complete paraplegia or complete tetraplegia, formerly known as quadriplegia. Paraplegia complete means you have permanent loss of motor and nerve function at T1 or below. Loss of sensation and movement in legs. You have loss of sensation in bowel, bladder, and the sexual region. We know that the arms and the hands usually retain normal function. And some people will have partial trunk movement, so they can stand or walk with assistive devices. But most will use wheelchairs that are self-propelled. Tetraplegia is defined as paraplegia and loss of arms and hand movement, although some may have a bit of hand and arm movement. The incomplete spinal cord injuries are divided into 5 classes. And with incomplete, it is determined after spinal shock subsides, which is about 6 to 8 weeks after injury, and can result in some movement, but little or no feeling. So let's talk about the 5 classes of incomplete. Anterior cord syndrome is the first one. It is usually damage to the front of the spinal cord. It usually results in impaired temperature, touch, pain, sensation below the injury. Some movement may be recovered. Second class is central cord syndrome. Damage in the center of the spinal cord, which results in loss of function in the arms, but some leg movement, with some recovery possible. The third class is posterior cord syndrome, which is damage to the back of the spinal cord. You have good muscle power, pain, and temperature sensation, but poor coordination. The fourth class is Brown-Séquard syndrome. It's damage to one side of the spinal cord, which results in impaired loss of movement, but preserved sensation on one side of the body, and preserved movement and loss of sensation on the other side. So one side of your body has impaired or loss of movement, but good sensation, and the other side has preserved movement, but loss of sensation. The final incomplete class of spinal cord injuries is cauda equina syndrome, or lesion. This is injury to the nerves located between the first and second lumbar region. You can have partial or complete loss of sensation, and in some cases the nerves regrow and function is recovered. The degree of impairment usually is assigned using the ASIA, or the American Spinal Cord Injury Association scale, which grades based on sensory and motor function. Usually, along with physical assessment and history, a MRI is done, and it is the most sensitive imaging test of the spine. So I don't want you to get caught up in what the assessment findings are for each, but I did want to go through the classes and let you know that there are different aspects of the spinal cord that is injured and what the recovery is. So on assessment, we know that what we find on assessment usually depends on the type and the level of the injury. Okay, so what can we see? We can see paresthesias, which are usually related to mild injuries. We can see loss of sensory and motor functions, so paralysis. We can see loss of bladder or bowel control. We can see acute pain in the back or the neck. We may have respiratory problems depending on the level of the injury. And as I mentioned, high cervical cord injuries usually account for acute respiratory failure. We also know bradycardia and asystole are common in acute cervical injuries. So now let's talk about the two major complications that we see with spinal cord injuries. The first one being spinal shock. Spinal shock is defined as a state of temporary reflex suppression below the level of injury. It generally occurs immediately after the cord injury or up to 1 hour after the injury. It is characterized by hypotension, bradycardia, and warm, dry extremities, and that is due to a reflex vagal activity. We'll see vasodilatation and loss of sympathetic activity. We'll also see a flaccid paralysis of skeletal muscles. We may see an absence of sensation and proprioception below the level of the lesion, and transient urinary and fecal retention. We may see a loss of vasomotor tone, which results in unstable, lowered blood pressure. We may see that body defenses have to be supportive and maintained until spinal shock goes away and the system recovers from the traumatic insult. So pay very close and special attention to the respiratory system, as we may not be able to generate enough intrathoracic pressure to cough effectively. So we may need some chest physiotherapy or suctioning to assist clearing pulmonary secretions. The duration usually varies greatly from a few minutes, days to months, but in general usually lasts anywhere from 1 to 6 weeks, and 6 weeks is generally what we see. But a lot will depend upon how severe the spinal cord injury is. We do know that recovery is gradual. How do we know that we're getting better? Indications are that we have a return of reflexes. Patients may actually see muscle spasms and a reflex emptying of bowel and bladder. When spinal shock has resolved, and possibly an MI. So what are your interventions? First off, place that patient in a sitting position, high Fowler's, 90 degrees. Then remove any TEDs or SEDs to decrease venous return and lower the blood pressure. Page your physician's stat. Call out. Do not leave the patient, but page them stat. Loosen any restrictive clothing, and then look for a cause. Look if they've got a Foley in. Look for any kinks in the Foley. Maybe that the bag is not draining well and it's created a kink in the tubing. Look to see if there's any bladder distension. You may have to check for fecal impaction, and then check the room temperature for coolness or draftiness. We want to monitor their blood pressure every 10 to 15 minutes and administer nitrates or other meds such as apresilene to get their blood pressure down. So now, what are some of the nursing diagnoses associated with spinal cord injuries? Number one, ineffective or risk for ineffective breathing pattern related to interrupted spinal cord impulses. We can also have ineffective airway clearance. We can have a risk for decreased cardiac output related to loss of vascular tone secondary to spinal cord injury. We might have impaired physical mobility related to loss of muscle control below the level of the spinal cord injury. We could have a risk for ineffective tissue perfusion, peripheral, a risk for injury, altered sensory perception, risk for impaired skin integrity, and you could go on and on and on down the line. So what are some nursing interventions for spinal cord injury? Well, let's talk about immediate management first. If we come upon someone who has a spinal cord injury, one of the first things that happens is we don't want to touch them, if at all possible. But if not, we want to make sure that we move them all as one piece, just one whole movement, and hopefully you don't have to move them so as to prevent any further injury. But once EMS arrives, then usually patients are immobilized on a backboard with their head in a neutral position. So we want to make sure that we keep the back straight. We want to prevent flexion, rotation, or extension of the head or neck until cleared by X-ray. We want to make sure we have a patent airway. And in some patients, they may need mechanical or manual ventilation, especially if they have had cervical injuries. We may have to administer supplemental oxygen to those who don't have to have mechanical ventilation. We want to maintain a high arterial PO2 because we know that hypoxemia can worsen neurologic deficits, especially thoracic injuries. We want to closely monitor their vital signs. We know that the blood pressure tends to be unstable in the first 2 weeks after a spinal cord injury, but it will gradually return to pre-injury levels. But those patients generally have frequent episodes of severe orthostatic hypotension. So during this time, we may need to administer vasopressors to keep the blood pressure elevated. We also want to make sure that we incorporate slow position changes and use TEDs or SCDs to help increase blood flow. We always want to make sure that we maintain proper alignment. And one of the best ways to make sure that patients are in proper alignment is by going to the foot of the bed and looking at your patient and seeing, are they lined up? Do they look like they're all in one line, or are they crooked or bent to one side? We want to make sure that we do range of motion to prevent contractures. In the immediate management, many times patients will have indwelling urinary catheters, and then they may later go to intermittent catheterization. We know with spinal cord injuries that the bladder can become atonic and can't contract reflexively, and that patients usually have no sensation of bladder distension. So what happens is the bladder gets overstretched and we have a delay of return of bladder function. But we do try bladder retraining if the return, to get some return of bladder function. Initially, we may also insert an NG tube to decompress the bowel. Generally, at some point, most patients, be they paraplegic or tetraplegic, will develop a paralytic ileus. There's usually just no way around it. When bowel sounds return, we generally want patients to be on high calorie, high protein, high fiber diets. We also want to monitor for DVT, which we know there is a high occurrence, which can lead to PEs or pulmonary emboli, which is a big killer of patients with spinal cord injuries. Excuse me. Medication-wise, we know that these patients receive many different meds. First off being high-dose steroids. Within 8 hours of the injury, we try to give high-dose steroids to improve neurologic recovery. One of the biggest steroids we use is methylprednisolone because we know that it prevents further damage and promotes recovery in some people. However, we know that it is controversial due to the side effects. Another study that's going on is the use of Freedox, F-R-E-E-D-O-X. It's in animal studies now, and it has to be administered in the first few hours after the injury. It's usually used with methylprednisolone, which has less side effects, the Freedox does. It also helps to decrease the inflammation at the site. Another drug which is experimental is Cygen. It's given within 72 hours and continued for 32 days. It has showed significant amount of functional recovery for patients with spinal cord injuries. However, it is not yet approved by the FDA. We know vasopressors are used in acute injury for spinal shock and neurogenic shock. We may use dopamine for blood pressure, dobutamine for cardiac support, and atropine for bradycardia. Antispasmodics are also used for those muscle spasms that patients have as recovery is starting. Drugs like Valium and baclofen, B-A-C-L-O-F-E-N. NSAIDs or narcotics are also used for pain. Anticoagulants to prevent DVT. PPIs, proton pump inhibitors, to prevent gastric stress ulcers, and stool softeners are used. I want to say that they'll use surgery-wise is what they call an omentum surgery, where they actually detach part of the omentum and tunnel it to the injury site. And this has to be done about 3 hours after the injury. And what we know is the omentum will supply the damaged nerves with oxygen because it has a big blood supply that secretes chemicals that stimulate nerve growth. And this is typically not done very often, but in some places where you've got big spinal cord regions, where they have the big spinal cord centers, depending upon where the spinal cord injury is, this may be done, where they actually go in, take part of the omentum, and tunnel it into wherever the site of the injury is along the spinal cord. You don't hear of it too much, but it may be something that we may see coming more commonplace later. Okay, let's move along to nursing care of critically ill neuro patients. And what we're going to talk about now are brain injuries and their treatment. So, traumatic brain injuries, or TBIs, are classified as, or there are a couple of types. There are the open and the closed. So let's talk about the open classification. An open brain injury or traumatic brain injury occurs when an object pierces the skull, enters the brain, and damages the soft brain tissue, or when blunt trauma is so severe that it opens the scalp, skull, and dura to expose the brain. So let me repeat it. Open brain injuries occur when an object pierces the skull, enters the brain, and damages the soft brain tissue, or when blunt trauma is so severe that it opens the skull, the scalp, the skull, and the dura to expose the brain. Most of your penetrating injuries are due to either gunshot wounds or knives. We know the basilar skull fracture is the most severe, and generally we see cerebrospinal fluid leakage from the nose and the ears. And this cerebrospinal fluid leakage comes or is due to the injury of the dura. So upon assessment, what do we see when people have these types of open spinal cord injury? We may see bilateral bruising around the eyes, and that is known as raccoon's eyes. It is a late sign for an anterior fossa fracture. You may see unilateral bruising behind the ears and down the same side of the neck, and that is called battle sign. And this is usually seen when you have a basilar skull fracture of the middle fossa. You may see rhinorrhea, which is a CSF leak, and it's a runny nose. It's a clear fluid coming from the nose. And generally we test with a dextro sticks, or just one of our glucose sticks. And if it's positive for glucose, then we know that it is a cerebral spinal fluid leak. If by chance it's bloody, we look for a halo sign, meaning that you take a little white 3x3 or 4x4, let the blood drop on the 4x4, and see if it's surrounded by a yellowish area. If it's surrounded by a yellowish area, we call this a halo. So this is a positive halo sign for a CSF leak. Generally, we see these due to fractures in the anterior fossa. Otorrhea, which is a leakage from the ear, clear leakage, or could be bloody, is usually due to a fracture in the middle fossa, and this too is due to a cerebral spinal fluid leak. So we definitely test the same way, either by dextro stick, letting a little bit of that fluid fall on a glucose strip, or letting a little bit of the blood from the ear fall on a 3x3 or 4x4 and watching for the halo sign. So up here we can see the rhinorrhea, the otorrhea, the battle sign, and the raccoon's eyes. The other classification that I want to talk about with open before I go on to closed is a laceration. And a laceration is a tearing of brain tissue that occurs with a depressed, compound fracture, and penetrating injuries. So it is severe tissue damage. Generally, you'll have an intracerebral hemorrhage, which results in unconsciousness, hemiplegia on the opposite side, and dilated pupil on the same side. So when we see hemiplegia on the same side, on the opposite side, that's called the contralateral side. And if we see dilation of the pupil on the same side, that's called the ipsilateral side. So with this laceration, if we have an intracerebral hemorrhage, we'll see unconsciousness, hemiplegia on the contralateral side, opposite side, and the dilated pupil on the ipsilateral side, the same side. And we do know for patients whose bleed is large, there is a poor prognosis. Now, the other classification of brain injuries is the closed brain injury. It is the most serious. It can be due to blunt trauma or when the brain has been caused to slosh back and forth inside the skull. No fracture needed. We know that closed types of brain injuries can be a concussion or a contusion. Concussions are usually mild traumatic brain injuries. So, with that, concussions can be subdivided into a mild concussion or a classic concussion. A mild concussion usually results in a memory lapse at the time of injury and a brief loss of consciousness, usually less than 30 minutes. You can have transient confusion or disorientation. A classic concussion results in loss of consciousness that usually lasts less than 6 hours, and it's always accompanied by some degree of amnesia. Upon assessment with a classic concussion, you'll usually see headache, nausea or vomiting, confusion or feeling like you're in a fog, amnesia surrounding the traumatic event, dizziness or seeing stars, ringing in the ears, slurred speech, and fatigue. A contusion is considered a moderate to severe traumatic brain injury. A contusion is defined as bruising of the brain. Contusions can be classified also as acceleration, or let me just say, there are 3 types. Due to an acceleration injury, a deceleration injury, or a coup contre coup phenomenon. So let me explain. An acceleration injury is when your head is hit by a moving object. So say someone has come along and they're swinging a book, or you get hit by a soccer ball that you didn't know, or by a baseball. So your head is hit by a moving object. A deceleration injury is when your moving head hits a stationary object. So if you're in a car, if your head is moving forward and hits a windshield. The coup contre coup phenomenon is when you have an injury at the site of impact, which would be the coup, and the opposite of the brain. So you have an injury at the site of the impact, the coup, and the opposite of the brain, the contre coup. So generally what this means is an impact forces the brain to move to the opposite side of the skull. So let's say that you have you may be hit from behind in a very bad car accident. Your brain sloshes forward like a whiplash. It goes forward inside the skull. You don't hit an object, but the impact from where you were hit from behind is so hard that your head moves forward and the brain sloshes forward. And then that impact is so hard that after that your head moves back and your brain sloshes back to the back of the skull. So that's called a coup contre coup. So it can happen from a car accident after like a high-speed stop. Or we see this in shaken baby syndrome, and think if someone shaking a baby in their head moving back and forth and the brain actually moving back and forth. And as we know, those babies usually do not survive. So upon assessment, we usually see generalized disturbances in level of consciousness. We can see stupor and confusion, and seizures are very common. Patients usually decline over the first 72 hours due to swelling. So what happens with these traumatic brain injuries? Well, generally one of the first things we see is an increase in intracranial pressure, ICP. It's the primary complication. It is the leading cause of death in head traumas who reach the hospital alive. Normal ICP, according to your book, and this is what we'll use, is around 5 to 10 millimeters of mercury, 10 to 20 being mild elevation, or mild to moderate elevation, and greater than 20 being severe. We know with trauma the cerebral spinal fluid is displaced and absorption of fluid increases, or cerebral blood volume decreases by displacement of cerebral venous blood into the sinuses. So think about your Monroe-Kelly hypothesis here. So with an increase in intracranial pressure, when compliance can no longer be maintained, you're going to see pressures go up in your head, a decreased cerebral perfusion, resulting in tissue hypoxia. We'll see a decrease in your serum pH, an increase in your PCO2s, which will cause cerebral vasodilatation, and then which will result in edema and an increased intracranial pressure. So it's a vicious cycle, and that's why these patients will die if something is not done. Early symptoms are usually changes in level of consciousness, papillary changes within the eye itself, weakness on one side or extremity, and a constant headache that increases in intensity and movement. Other potential problems that can occur are hemorrhage. This usually occurs from vessel damage. Epidural bleeds occur about 2 to 6% of TBIs. They're usually due to a skull fracture or contusion. And the common site is the temporal bone. These are considered neurosurgical emergencies because they involve arterial bleeding. So patients that have epidural bleeds usually have brief periods of cognizance or lucidity, and they generally will have bleeding between the dura and the inner surface of the skull. 29% subdurals have a 29% occurrence in TBIs, and these are mainly venous bleeds. They occur between the dura and the arachnoid space, and they usually develop slowly. We see chronic subdurals common in the elderly and those who are chronic alcohol users. So that's why you'll hear of elderly patients that fell 2 weeks ago and are just now, or over the course of the weeks, have gotten increasingly confused, but nobody brings them into the hospital until the confusion has hit a max peak or they've become unresponsive. Finally, the last hemorrhage that can occur is the intracerebral. Usually they have a 14 to 15% occurrence. These develop within the brain itself, and usually the frontal and temporal lobes are the most affected. The most common causes are a gunshot wound, depressed skull fractures, stabs, contusions, or long history of systemic hypertension. So those patients that have had hypertension for a long period of time that have never gotten it under control, or those that have come off their blood pressure medicine and have been off of it for a while and have not checked it and basically have a big stroke. Another potential problem is hydrocephalus, which is an abnormal increase in cerebral spinal fluid volume. This can also lead to an increase in ICP. With hydrocephalus, we try to get these under control by putting in a ventral drain. So a lot of these patients will have drains. Finally, one of the biggest problems is the ability for the brain to herniate. Generally what we see, it's due to the brain tissue shifting and moving downward. Assessment findings with brain herniation are usually patients are unarousable. They have extreme motor weakness. You may see posturing or absence of muscle response. Pupils are unilaterally dilated or blown and fixed. And most definitely you will see the Cushing's triad, the elevated systolic blood pressure, wide pulse pressure, bradycardia, and irregular respiration. Other potential problems usually deal with fluid balance disruptions. And those two problems that can occur are diabetes insipidus and SIADH, syndrome of inappropriate ADH. Let's talk for a minute about these two fluid balance disruptions. First, with diabetes insipidus. We know that diabetes insipidus results when there is a decrease in ADH, which causes an increase in fluid to be excreted through the renal system. The urinary output is increased, and the specific gravity of urine is decreased. In the acute phase, if the urine output is greater than 200 milliliters per hour for 2 hours, then that usually is an indication of the onset of diabetes insipidus in our head trauma patients. At this point, we administer IV fluids, we do electrolyte replacements, and usually these patients get DD-AVP. In patients that have SIADH, we know that this involves the release of ADH even when it is not needed. So it is the opposite of diabetes insipidus. So what we see here is urine output is decreased. Serum sodium concentrations decreased, and this is referred to as a dilutional hyponatremia. What we need to remember is that the more severe the hyponatremia, the greater the effects on cerebral functioning. And hyponatremia may produce serious symptoms such as seizure and coma. Generally, these patients will be placed on a fluid restriction of less than 800 milliliters per day with no free water. And sometimes patients will receive 3% hypertonic saline. The last potential problem I want to mention is just seizures in general with traumatic brain injuries. And I'm not going to review seizures and medications. You've already had that. So I want you to go back and review on your own what at least Dilantin, the seizure medication Dilantin, know the side effects and that the therapeutic range for Dilantin, and what you need to do for teaching your patients. Nursing diagnoses for traumatic brain injuries include ineffective tissue perfusion cerebral, hyperthermia, as well as acute pain and anxiety. The goals with patients that have traumatic brain injuries should be to decrease cerebral edema and restore cerebral perfusion. So let's look at some nursing care. First of all, we want to assess the airway and the breathing pattern. Remember, don't worry about the name of the breathing pattern. Just know that there is a difference in breathing pattern. Some patients may need ventilation. So if they have to have mechanical ventilation, we know that we're going to monitor their ABGs. We're going to be assessing their pH, their PCO2, and the PO2. We know that elevated hydrogen and carbon dioxide causes vasodilation. We know that low oxygen causes hypoxemia, or is hypoxemia, which can cause vasodilation. So our goals here are to keep the PO2 at 100 or close to it and keep the PCO2 around 35. We want to make sure we do careful suctioning using care when we hyperventilate. And we should only suction these patients for 15 seconds. Vital signs are usually a late sign of problems going on or of increased intracranial pressure. So severe hypertension with increasing systolic blood pressure and a widening pulse pressure, as well as bradycardia, 50 or less, and the irregular respiratory pattern are our Cushing's triad. And remember, these are late signs. So we want to assess for level of consciousness, looking for changes or a decrease in level of consciousness. This is your first sign something is wrong. So restlessness, irritability, picking at something, or maybe just changes in conversation, like your patient was very lucid talking to you, very straight up, and now all of a sudden they're telling you, you know, I have something over there, it's been over there for a long time, and they're talking about another room or another space or something just out of the ordinary that just doesn't quite hit it. So look for those little small changes in a level of consciousness. We also want to make sure we assess the pupils measured in millimeters. If you see pinpoint and non-responsive, we know there's brainstem involvement. And also if we see dilated and fixed, we know that these are poor signs, noting that the patient is really going downhill quick or has gone downhill and may be irreversible. We want to assess for bilateral motor responses. Watch for a decrease in motor functioning or development of abnormal posturing. And so we're looking for decerebrate or decorticate posturing. With decerebrate posturing, all extremities have rigid extension. And there are pictures in your book of this. I also have pictures here on the next slide. With decorticate posturing, you have flexion of the arms, the wrist, and the fingers, and adduction of the upper extremities. So, in the lower extremities, you see extension and plantar flexion. On to this next. So, this first picture shows the decerebrate posturing. Everything's extended. All the extremities are extended. And if you notice at the wrist and the hands are very well rigid and flexed. When you look at decorticate rigidity, you're looking at the lower extremities being rigid and flexed, or rigidly flexed. And then you'll see that the upper arms from the elbows up are flexed toward the cord. And I always like to say decorticate, remember, towards the cord. Those extremities, the upper extremities, come up and towards you. So that's one way to help you differentiate between decerebrate and decorticate posturing. We also want to assess for severe headache, nausea, vomiting, and seizures. We want to observe for cerebral spinal fluid leakage, that rhinorrhea or otorrhea coming out. We want to make sure that we can either use a glucose test or a halos test to see if for sure it's a CSF leak. We want to monitor ICP during nursing interventions. We know that ICP should not increase more than 25 millimeters of mercury and should return to normal within 5 minutes. For your, whenever you're doing an ICP check or monitoring, when people have ICP monitors in, the head of the bed should be at 30 degrees when they're measuring. We want to monitor for cerebral perfusion pressure, CPP, and that is the pressure it takes for the heart to provide the brain with blood. If you have a low cardiac output, then you can't maintain adequate cerebral perfusion, so your CPP will be decreased. CPP, or normal cerebral perfusion pressure, should be between 70 to 95. One way you can figure out your cerebral perfusion pressure is use your mean arterial pressure minus the intracranial pressure. We want to make sure that patients that have traumatic brain injuries, that their head of the bed is elevated 30 to 45 degrees, and that we keep their head and neck in alignment and avoid any neck flexion. We want to make sure that we maintain glucose levels between 80 and 110, and if what we've found is that increased levels of glucose have increased the mortality in patients with traumatic brain injuries. We also want to maintain fluid and electrolyte levels. We will monitor sodium levels. We'll also monitor serum osmolalities. Serum osmolalities should be 280 to 300 milliosmoles per kilogram. And what this does is it measures the amount of dissolved particles in the serum. So we're measuring electrolytes, glucose, and urea. We usually like to keep patients slightly elevated at about 325 milliosmoles to draw excess intracellular fluid into the vascular system. So with that, we need to make sure we're doing accurate I's and O's. We want to make sure that we give patients rest periods, so we don't want to cluster activities. We want to make sure that we avoid the Valsalva maneuver, so we're going to give stool softeners. We're going to avoid bending, coughing, sneezing, or vomiting, or we want the patient to avoid these things. And when we have patients that have ICP monitors in, we want to maintain bed rest with careful turning, because we know turning can increase ICP. So we may want to instruct our patients to exhale to avoid any Valsalva maneuvers while turning. Also, we may want to do things like limit visitors and absolutely meds or temperatures for these patients. ICP monitoring is usually done with an intraventricular catheter, which can also act as a drain. And these are put in by putting in little holes in the skull, through the skull, which are called burr holes. With this, we know that there's a risk for infection, hemorrhage, or over drainage. Okay. And I'm not going to go into any more detail about these catheters. Mentioned head of the bed 30 to 45 degrees, mechanical ventilation may be needed, and then absolutely there are medications that are involved with care of these patients. So let's go through some of the medications that you're going to see. First off, we may see the administration of osmotic diuretics. One of the biggest osmotic diuretic given is mannitol or osmotrol. Mannitol is spelled M-A-N-N-I-T-O-L. Mannitol is given to treat cerebral edema by pulling water out of the extracellular space and into the blood vessels where it can be excreted by the kidneys. Let me repeat. It is given for the treatment of cerebral edema by pulling water out of the extracellular space and into the blood vessels where it can be excreted by the kidneys. It's usually administered in IV boluses. And generally, these patients usually will have a Foley during this time to make sure the fluid volume is being managed well, and we can keep up with things such as urine osmolalities. Another type of drug that's given with, in addition to mannitol, are loop diuretics, so Lasix being the #1 loop diuretic you'll hear about. It's usually helped to reduce the edema and blood volume, and it can also lower sodium uptake by the brain and the production of cerebral spinal fluid, which is important in traumatic brain injuries. So we're going to monitor serum electrolytes and serum osmolality levels and urine osmolality levels. So strict INO needs to be kept up with. We also may see NMBAs, neuromuscular blocking agents. These are drugs that have no analgesic or sedative effects, but they're used for excessive agitation or if increases or if you have increased ICP. These NMBAs decrease metabolic demands, thereby decreasing cerebral oxygen demands. And while I said most of them don't have any sedative effects, one that they do use that does have sedative effects is propofol. So, for the most part, propofol is now being used and it does have sedative effects, as we know, as we've heard from the media. The biggest side effect in using these NMBAs is hypotension. I did mention anticonvulsants, anti-seizure meds. Usually Dilantin is used for seizures that occur within 7 days of the trauma. It's most widely used. That's why I want you to go back and review that drug. Some patients with severe traumatic brain injuries will be placed in a barbiturate coma, and this is done when all else fails to get a patient through the tough times with increased ICP. And what happens is this produces a decrease in cerebral metabolism, which will decrease the ICP. Drugs that are used are Nembutal, Nembutal, or pentothal. Major side effect being hypotension as well. Other drugs we'll see are corticosteroids. Dexamethasone is the primary one used, and usually you'll hear the name Decadron for dexamethasone. This drug acts by their stabilizing effect on the cell membrane and by inhibiting prostaglandin synthesis. So they can also improve neuronal function by improving cerebral blood flow. When patients are on these corticosteroids, however, you're going to see the addition of antacids, H2 receptor antagonist, or proton pump inhibitors to decrease the risk for GI complications or ulcers. Finally, the other things you may see given are your antipyretics. We know antipyretics are very common because we do see hyperthermia in these patients. So we want to decrease oxygen and metabolic demands to help protect the brain from ischemia. So acetaminophen is widely used. We also, in conjunction with acetaminophen, will see cooling blankets and ice bags, which are not meds, but are used in conjunction with the antipyretics. Remember, when you use ice bags, that the primary places to place them in patients that have hyperthermia due to brain injuries are under the armpits and groin area and behind the neck. Finally, with treatments with traumatic brain injuries, we also see IV fluids being given to maintain fluid and electrolyte balance. So we'll see 1/2 normal saline or normal saline. And then it's kind of an oxymoron kind of thing. We'll see fluid restrictions. will put patients in state of dehydration or hemoconcentration to draw fluid across the osmotic gradient and to decrease cerebral edema. So those are your main treatments or nursing care of traumatic brain injury patients. Finally, I want to talk about the 5 abnormal states of consciousness and disabilities that occur from traumatic brain. Your 5 abnormal states are stupor, coma, vegetative state, locked-in syndrome, and brain death. So let's start with stupor. In stupor, patients are usually unresponsive but can be aroused briefly by a strong stimulus, sharp pain. With coma, patients are totally unconscious, unresponsive, unaware, and unarousable. There is no response to external stimuli, light or pain. They do not have sleep-wake cycles. The eyes are generally closed. And it may last from a few days to a few weeks. We know that coma usually results from widespread or diffuse trauma to the brain, upper and lower brain, and the brainstem. And patients will either progress from coma to a vegetative state, or they may die. A vegetative state is when people are unconscious but have sleep-wake cycles with some periods of alertness. The eyes may open. Patients may groan, move, or show reflex responses. Patients may emerge from a vegetative state in a few weeks. Excuse me. And if not after 30 days, they are termed to be in a persistent vegetative state. Adults, it's said to be, have a 50% chance of recovering consciousness from a persistent vegetative state within the first 6 months once they are deemed in this state. After a year, chances of recovery from a persistent vegetative state are very low. And if they do not come out of it after a year, they usually have some severe disability. Locked-in syndrome occurs when you have complete paralysis of the body. The patient is aware and awake, but cannot move or communicate. It's caused from a specific damage to the lower brain and brainstem. Communication is often accomplished through eye movement and blinking, which is the only thing or area not affected. Brain death is a lack of measurable brain function due to a diffuse damage to the cerebral hemispheres and the brainstem. We know this is irreversible. And there are many tests to see if brain death has actually occurred, and I'm not going to go into those. So what do we know about disabilities from traumatic brain injuries? Well, we know that disabilities are dependent on the severity of the injury, the location of the injury, and the age and general health of the patient. So the areas that we're looking at are first cognition, then sensory, then language and communication, and finally emotional problems. In the cognitive area, we're looking to see, do they have memory loss, the inability to store memories? Are they easily confused or distracted? Do these patients have problems with concentration? Do they have a hard time with planning, organizing, problem solving, and making judgments? In the sensory area, we're looking to see how is their vision? Do they have an inability to register what they are seeing? Do they have problems recognizing objects? Are they slow to recognize them? How is their hand-to-eye coordination? Does it cause them to bump into objects? Do they seem unsteady or drop objects? How is their hearing? Do they have roaring in the ears or ringing in the ears? Do they have a persistent bitter taste or a persistent noxious smell or odor that they're always encountering? With language and communication, we're looking for aphasia. We're looking for hard to understand body language, for difficulty in understanding body language, or looking at their emotions and nonverbal signals. We're also looking for dysarthria, D-Y-S-A-R-T-H-R-I-A. Can they think of the word they want to say, but cannot easily speak the words? Speech can be slow, slurred, and garbled. People with TBIs may have emotional problems as well. Depression, apathy, anxiety, irritability, paranoia, frustration, agitation, insomnia, mood swings, or even aggression. So what do we see possibly as long-term problems from TBIs? Well, one disease is Alzheimer's, and this is usually related to head injuries in early adulthood. The more severe the head injury, the greater the risk. Parkinson's disease may also develop years after a TBI as a result of damage to the basal ganglia. We're seeing a lot of Parkinson's in patients, in pro football players. We're also seeing them in boxers, professional boxers. And with that, even some Alzheimer's. We also see movement disorders, tremors, or ataxia, which is uncoordinated muscle movements. We may also see dementia pugilistica. This primarily affects career boxers. Symptoms begin between 6 and 40 years after the start of a boxing career, with the average onset of about 16 years. And this is the combination of dementia and Parkinson's. And then finally, we may see post-traumatic dementia, like dementia pugilistica, but also have long-term memory problems and is caused by a single severe TBI that results in coma.